Bismillahirrahmanirrahim. I am thankful to the previous all the speakers because they have made my life easier. Because what I've seen that they have already discussed most of the things which we want to discuss, and so it will be easier for you to tolerate me because by hope there will be no problems because we are all used to work with empty stomach and full bladder. So I think you will be able to tolerate for a few more minutes, and I'll be starting because my topic was left main disease and multivessel disease, but I just skipped and I was focusing on left main interventions and how to make an approach for the left main disease. So let's start with the incidence. We know that it's a disease with high morbidity and mortality, and it's visualized around 3 to 5% of all coronary angiograms. This is international data, but we see that overall there is variable data because of many things. Because of different study populations, people, if you take a group of ACS patients, you will have different. If you are doing high risk patients, you will get more left main patients. If you are not doing, you're just doing stable patient, you will get less patients. Similarly, different cutoffs. In one of the Pakistani studies, they showed that they have got 10% left main disease. So, but finally, when we looked into the data, they included all mild left main disease and moderate disease also. So they said that this is 16% in one of their studies in Aptaval. So different cutoffs, and similarly modalities used. If you are using IVUS for your standardization of left main disease, you will get more left mains and you will pick most of them, or FFR or any other things. So incidence is different. But what about NICVD? So we have got our own data, and this was pre-COVID when we were doing everything. So we found out, this study was published in Journal of Ayub Medical College, and we found that out of 11,000 all-comer patients, the left main disease was there in 3% of the patient. Looks smaller, but if you see that we do around 100 cases a day. So when you are doing 100 cases a day, you will see 3 left mains a day. So it's if 3%, they say it's 3%, okay, so you get 97% reducing. But if you see 3% and you are doing 100 cases, 100 angiograms a day, and ICVD, when we work full-fledged, we found 3 left main stem a day. The average age was 55, young patients. And most of them were symptomatic CCS2, CCS3. This is enough to understand that what is the level of the disease we are going to handle. But what happens when you do this? This is something which we see very commonly nowadays, because we are doing high risk patients, and in ACS patients, when you do these kind of things, you leave all data, और आपके सारे के सारे जो techniques हैं उस वक्त के अंदर आपके, when you bring patients doing CPR and you find a few minutes of ROSC and you bring the patient in and you take that. This patient we took directly guider because it was a 40-year-old male patient, recurrent VTs, VF intubated. We had to do CPR and we brought, for few minutes, we got some time and we brought the patient in and we found this one. So this is the thing we are handling. So what is the international data? Acute MI patients, meta-analysis, around 18 centers, a lot of patients, they found out that significant left main disease occurs in 4 to 7% of all acute MI patients. And out of them, unprotected left main as a culprit, you will get 4 to 7% as a whole. The left main may not be the culprit. You will get some chance to go through the left main, and we all do it. We go through this significant left main and we open the circ and we say कि जी बाकी काम surgeon कर लेगा. लेकिन as a culprit lesion, it's also there in 0.82. You'll say 1%, or so again you may see one left main culprit lesion a day. So what I meant to say, majority of them in cardiogenic shock. What I mean to say is that left main intervention is not optional for interventional cardiologists. It's a compulsory skill and it's a life-saving skill. So we need to focus on left main skills. There were times when I was 10 years ago, I was in training, we used to hear from some of the bosses that this guy will do left main and this guy will not do left main. But it's not option now. 10 days ago, 10 years ago, you are a left main operator, you are not a left main operator. But nowadays, if you are interventionist and if you are not doing left mains, don't say this thing to your wife. वो आपको या अपने husband को जिनके, otherwise you'll have to cook yourself. लेकिन if you cannot stand the heat, leave, please get out of the kitchen. So that's a famous saying that left main intervention is a compulsory skill for all interventionists. So we'll see how to approach a left main. You have got a patient with significant left main disease. One thing you want to consider for left main intervention, whether you want to send, when you are evaluating the left main lesion site, ostial left main, we will discuss, ostial and mid-shaft lesions are usually considered simpler and they can be done easily, but distal left main is different animal. It's a different strategy, like Dr. Javed Syal has already discussed. We will be touching those things. I will be going through those slides very quickly. But distal left main is a different thing. Similarly, anatomy, overall anatomy, despite all limitations, syntax score remains a reasonable tool to grade the extent of coronary artery disease. Whatever you say, whatever the data is, final conclusion is. So I'll be discussing most of the conclusions. I'll not be going for a specific trial. What is the final conclusion? Is still, if you go for Excel trial, basically they were against syntax and they said that the syntax score is not that reliable tool to assess. But in Excel trial, they basically, those extensive triple vessel disease patients were excluded. So that's why still syntax score is a good tool. Similarly, whatever the syntax says, your main approach may be according to the situation. Clinical may play a major role in your decision making. A patient with a high syntax score you want to send, but the patient is ACS and left main is culprit. You cannot wait for it. You have to fix then and there, like the image which I showed. You cannot say, जी इसका तो syntax ज़्यादा है, इसमें तो LED total है, इसमें फलाना है, इसको जे. बल्कि कोई कहेगा कि who went to calculate syntax score? इसमें उसको बुला के ले आओ जरा उसको कि वो कौन था जो syntax score calculate करने खड़ा हुआ था, उसको ले आओ उसको आगे. So basically time is muscle. So clinical sometimes, most of the time, will tell you, and procedural factors. After a few slides, I will be discussing some most important procedural factors, and then we will come back again. So similarly, what type of revascularization you want to do for left main scan, you will consider which one will lead to ensure complete revascularization, because the whole thing, final conclusion that comes out with all the data is that CABG most of the time provides ensure complete revascularization. That's why there are more studies nowadays for the PCI. They are trying to do more stenting and going for even non-viable areas. They don't go for viability and they try to open it so that they can match their results with the CABG. So the things are going there. But even if you are selecting a patient of left main disease for stenting, you will try to minimize residual syntax score. We should have a concept of residual syntax score. एक ज़माने के अंदर हमारे जो senior होते थे, they simply what they used to do, if you have a lesion in LAD and you have a lesion in diagonal and you have lesion in OM, they used to place their hand on LAD and say, suppose this LAD is not there. It's normal. This LAD is normal. Would you like to go for this diagonal or this OM? If that is the thing, the residual syntax is. That is the residual syntax is. That if the residual syntax, the lesion, if still they need revascularization, then you should go for surgery. So a lot of progress has been achieved, but long-standing gap favoring CABG versus PCI still remains. After all of this one, still you decide now our approach, because we are discussing our approach towards the left main one. So still, if you have decided to go for intervention, think before you embark. Procedural factors. One of the most, मैं आपको एक जुमला बताऊंगा. When I was in training outside, so I started doing left mains in first 3-4 months. I called Professor Kundi. मैंने उनसे कहा कि सर लेफ्ट मेन काफ़ी करना शुरू कर दिए. तो वो हंसे बाकायदा तौर पे. उन्होंने मुझसे कहा, भाई साहब ये जो है ना, ये तो आपको सिस्टम करा रहा है आपके पीछे. आप जब यहाँ आएंगे ना आपकी परफॉर्मेंस 50% रह जाएगी. ये तो सिस्टम है वहाँ पे, एक पीछे सिस्टम है. व्हेन यू स्टार्टेड, दैट्स द थिंग विच वी हैव डेवलप्ड राइट नाउ इन NICVD. आई एम टॉकिंग 10 years ago. कि आप लेफ्ट वेन का पेशेंट आता है, एनेस्थीसिया को कॉल चली जाती है, बलून पंप लाके कोई रख देता है बराबर में खुद ही से, एग्रेसाइड के लिए स्टाफ तैयार हो जाता है, वो दूसरे को कह देता है भाई आ जाओ. There was a post fellow goes out and they counsel the attendants. So this is the system which is at your back. So most important thing is for satellite people and all other people, we need to see what are the procedural factors. So one is the indication. What are the potential problems I am going to face when I am going to touch this animal? Because most of the time it's around whole 100% supply of the heart. You have got a dominant circ or a non-dominant circ. What is the thing? What are the potential problems I am going to face if I am going to touch this one? Similarly, like Dr. Tahir Saghir हमेशा एक बात कहते थे, backup. What's your backup? आपके पीछे backup पे क्या है? What is your backup plan? If I fail, what is the backup plan? What next I will do? जैसे अभी डॉक्टर फवाद ने भी कहा कि जी you go with the plan, but you just go for a single stent and come out. Because patient safety is more important than any other thing. Similarly, if you are unable to do a kissing balloon at the end, it's better you go for a single stent and fix the thing and save the patient instead of doing something which is not complete and not durable. So what is your backup plan? And all the equipments are checked or not. So these are important interventional procedures, important steps before you embark and you go into a left vein intervention. Similarly, in case of emergency, you should have a rapid response. These are the things which we need to discuss. Good guide support, clear angiographic views. You cannot just put the stent in the left vein and now you are trying to find what is the adequate view for the left vein. You need to know what is the pre-procedural angiographic view, and that is the same view where I am going to land and from where I am going to start. So these are the things which should be there in your mind before you start. Similarly, keep balloon inflation shorter. This is one of the key points for the left vein stenting. You have got a first year PG standing there and he says 2, 4, 6, 8, 10, and you are doing a left vein. So that is an important thing. So similarly, another caution, no matter how advanced the next generation being implanted, additional efforts are still needed to improve PCI results. So Syntax 2 registries is especially emphasized the lesion selection with FFR and optimal stenting with IVS and OCT. So these are the key things for left vein stenting. Similarly, so in the modern era, they are considered as essential tool use of IVS and OCT. Keep things simple, as Dr. Javed Syal already mentioned. Provisional stenting would be appropriate and adequate in most of the left vein cases. But perform 2 stenting cases whenever is required. And the most important thing is, final result is more important than the technique used. Whatever the technique you use, final results are more important than the technique used. If you go for a DK crush and you go half-hearted, मैं एक जुमला पहले से कह देता हूँ जो आखिर में बात होनी है. I was studying the DK crush studies, and the editorial one, those who write the editorial comments, they are the most expert one on, and usually they comment on this one. And they said, you say these cases were done, but 95% were done in a single center. And majority of the operators were those operators who were doing DK crush for the last 2 years. So these results cannot be generalized. So you have to see how the results are. So like at the end, we will conclude, it should be individualized. It should be individualized. Your setup, your equipments, your backup, your patient's clinical situation, these are the things which will matter. So for ostial and mid-shaft lesions, we are discussing again separately. Or see if you got a severe ostial left main disease and you have planned, you have finally decided your equipment are okay, and you are going for an ostial left main lesion. They have got favorable results, relatively simple, immediate and long-term outcomes are good. Direct stenting is also technically feasible. There are pros and cons of every other things. If you pre-dilate, usually your stent movements are increased. अगर होता है तो stent आगे जगह पे फंसा होता है, लेकिन you produce more ischemia. So it depends on patient's clinical situation. You want to go for a direct stenting. If patient is stable, you can go for a direct stent. If patient is unstable, you would like to predilate, let it breathe a bit, let the flow go in, and then you can go for a stenting. So some technical tips. I'll be quick on this one because most of us are already doing these things. So epicranial or slight aleocranial, usually जो हम बार बार कहते रहते हैं aleo 20 cranial 20 is most of the time, more than 90% of the cases, this is a standard view. You can visualize ostial left main. Short tip guide are ideal. Avoid AL guider, also हम करते भी नहीं है वैसे भी. AL type of guiders, they usually try to stick into the left main and they can cause dissection and damage, and it's difficult to handle. So try to use, if you are doing a ostial short tip guides like JL or sometimes EBU. Guide disengage slightly from ostium by pushing gently on the wire. This is ये वो लोग कह रहे होते हैं basically those who use CTO wires only for crossing the hard lesion, and they exchange the wire just after they have crossed, they use microcatheters. If you are surfing your septal with a Gaia third, then you should not be doing this kind of thing. So if you are surfing your septal with a Gaia third and you push it to disengage the guide, then so isliye it's important that what is the wire you are using. But this is a conventional teaching that you can control your guider with the wire, but this is for the floppy wires. And simply stent deployed should be 1 to 2 millimeter protruding into the aorta. Inflation should be short, we have already discussed, and beware of longitudinal stent deformation. What is a longitudinal stent deformation? I hope you all have seen, because the newer generation stents are thinner strut, but they are comparatively softer. So once your guider sometimes inadvertently pushed into this, it can crush the stent longitudinal way, and this can have real worse effects. और सबसे ज़्यादा उस वक्त में होता है जब ये काम हो जाए और फिर आपका फेलो कहे कि मुझसे वायर भी निकल गया है. ठीक है, वो सर वो गाइडर अंदर गया था, मैंने पीछे किया तो वो सारा वायर भी बाहर आ गया. तो अब आप आ जाएं. So distal left main. So distal left main is again Dr. Syal has already discussed. I'll be touching and I'll try to be quick. If circumflex is occluded and less than 2.5 millimeter size or non-viable, you can leave it. It can be ignored. In a non-viable circ or a less than 2.5 millimeter size, it can be ignored. But or a circumflex is non-diseased. You have got a circumflex, jiska ostium pe disease nahi hai, overall circumflex is okay. Then you look for the angle of bifurcation. If it is T-shaped, or sometimes you get 70% se zyada ho, 70 degrees, but it's easier for me to remember it if it looks like a T. Even you can protection wire is often not necessary. If it is Y-shaped, then a protection wire is recommended. You can just directly go from a single wire and stent from left main to LAD. If the ostium is non-diseased. But if you have got diseased circ ostium, then side branch lesion length. This is another concept with a large bifurcation stenting study, that lesion length also counts. And this thing is, if the lesion length is less than 10 millimeter, most of the FFR will be negative. So lesion length also counts. और ये हम बचपन से एक बात बचपन से मतलब कि we used to think from कुंडी साहब का खास तौर पे एक जुमला होता था कि moderate diffuse is severe. Moderate diffuse is severe on FFR. So if you look at moderate lesion, इसी को reverse कर लें. Sometimes severe discrete may not be severe, may not be significant. So that is proven by the studies that if you have got a side branch lesion which is less than 10 millimeter of length, low risk of major adverse cardiac events, these can be left alone. So if you are deciding for two stent strategy, these are the points which we need to consider. Angle is T-shape, T-stenting or mini crush. Angle is Y-shape, Q-lot, crush, DK crush. As Dr. Syal has already discussed in detail, that most of the data is going in favor of DK crush study. So and DK crush stenting. But what I have learned, I've concluded by studying different studies, we have found out that it's not a matter basically of what technique you are using. The most important thing is that you prepare lesion, adequate lesion preparation. We have done some elective tap. We have done some elective tap. What we did, we followed all the protocols of DK crush. Wired, pre-dilated with NC, did IVUS, and then we go for a tap technique. And from this tap technique, we found results very similar. For the last 2 years, we are following patients and they are okay. So what we understand is that most important thing from these studies is lesion preparation. Lesion preparation should be IVUS guided, 1:1 with NC balloon, and adequate stent sizing. Again, type of the stent which you are using, this also counts. Newer generation stents are better but softer, as we have already discussed. And dot, which you said, dot is basically distal optimization. And again, सारे का खुलासा ये है, जो सारी जगह pot or dot is that you adequately post dilate the patient, the stent, and you ensure proper apposition of the stent. That's dot. That's pot. That you usually when you do a tap stenting, you don't go for post dilatation of the stent, side branch stent. You just post dilate with the same balloon. But if you do a post dilatation with the NC balloon, that is dot, distal optimization. So, and high pressure kissing. So, recrossing, that is an important issue, that from where you recross. I discussed with one of the expert of bifurcation that sometimes we have problem with crossing with the balloon. दोबारा balloon cross नहीं होता, 4 balloon use करना पड़ते. And he said to me that probably you are from the wrong strut. If you are from the proper strut, you should not have any problem with recrossing with the balloon. So they say try another strut. Okay, so proximal or distal strut DK crush, you have to cross from the proximal strut, tap or culotte from the distal strut, adequate post dilatation, final pot with the flash balloon. Flash balloon, what is a flash balloon nowadays for left main ostium? This is the balloon of this shape. You already most of us would have seen this thing. This is a balloon which is to flare the ostium stent. These are new balloons, flash balloon. Role of imaging, I'll be quick. Imaging, as we already know, okay, there when for short left main, when you cannot see lesions clearly, Dr. Naeem and Dr. Javed Syal already discussed about this thing, so I'm not going in detail. Catheter-induced spasm, ambiguous lesions. Minimal luminal area, again, it has already been discussed that usually most acceptable variable for detecting a significant lesion for left main only, IVUS. Minimal luminal area, if it is more than 6, you don't have to do anything, just leave it as it is. Don't have to evaluate further. But if it is less than 6, now there is a debate. And again, less than 5, less than 6, that you should be considering that it may be significant or may not be. Again, for Asians, there are different data. So there are some studies which have seen less than 4.8 is significant. Some studies they have said less than 4.1 is standard. For us in Pakistan, Karachi, we had one of the expert, I forgot his name, and from where he was a few years ago, he visited to us and we discussed this thing in detail. And for us, for Asians, for Indians, I think they suggested a minimal area of 5.6. So we usually in our practice, we usually follow a cutoff 5.6. If it is less than 5.6, you just directly go and stent it. That is the thing. But the people may have different ideas and different things. So we can do another study on it and find our own cutoff. Similarly, it plays a key role in assessment of plaque sizing, stent apposition, complication. OCT, again, already discussed, Dr. Naeem discussed with the OCT in left main is not indicated because it has got limited role, because OCT needs flushing with the dye. And you cannot flush ostium adequately and there is no way you can empty aorta with the blood. So that's why ostium cannot be, you cannot visualize left main ostium. That's why OCT has got this limitation. There were some studies in Europe ECR, they showed that they used a guider extension catheter. So they took the guider extension catheter very near to the left main and then flushed with the dye. So they are trying to make a room for OCT in this one, but still it's not clear. Similarly, FFR plays a significant role, a cutoff value of less than 0.88. I just wanted to use this platform for this point. In STEMI patients, there is no role of assessing a culprit lesion with FFR. There is no role of assessing a culprit lesion with FFR. I've seen people using FFR wire. रात को 3 बजे यूज हो गया जी, उन्होंने प्राइमरी PCI थी, उसके अंदर समझ नहीं आ रहा था कि लीजन कौन सा है, तो उन्होंने जो उसमें FFR किया था. So there is no point of doing FFR. Why so? Because a microcirculatory debris after the culprit lesion causes elevated microvascular resistance, leading to false elevation of FFR. Because of the slow flow kind of thing, you will have a falsely negative FFR. Okay? So, however, FFR is accurate in assessing additional lesions in the presence of multivessel disease. So, other lesions, non-culprit, you can evaluate with the FFR. It's a good tool, but not for the culprit one. And lastly, left main discussion cannot be completed. आपका फेलो आपको बुलाता है, कहते हैं सर पेशेंट को थोड़ा सा पेन हो रहा है. मैं एनजीओ कर रहा था और वायर भी मुझसे निकल गई है, उसके बाद जो है वो गाइडर में से पेन थोड़ा सा है, थोड़ा ये है, और जब आप जाते हैं तो सो डाइसेक्शन. So most important thing is that how you react on it. You need to be prepared for it. You have got this dissection. 10% is what happens to you. 90% is how you react on it. So most important thing is, so you have to be prepared for it and you control your nerves and how to, what are the causes. I'll be quick, मुझे वो दिखा रहे हैं, 5 मिनट रह गए, जल्दी से इसको करते हैं complete. So dissection incidence is 0.07%, demand urgent recognition and management. Causes we already know, but I just want to emphasize on this one. I'll be quick and I'll just want to, this one. Disengage your guide during any interventional device withdrawal. मैंने अपनी ज़िंदगी में जो पहली लेफ्ट मेन डाइसेक्ट की थी माशाल्लाह से, उसके अंदर जो है वो यही था कि when we finished, I was taking out the NC balloon, and when I took out the NC balloon, I found, oh. So when you're taking out your device, the guider is sucked in. And that is the time, इसलिए you need to be very careful. If your guider is not coaxial or pressures are damped, most of the time it will not cause dissection. But when you go through with non-coaxial guide and you take the balloon in and you pull the balloon out, that is the time the guider goes in. So this is the most important point in prevention of that. Disengage your guide during any interventional device withdrawal to avoid inadvertent forward movement of the tip of the guide into the left vein. So, and management, again, secure the wire. Don't lose your wire, don't lose your nerves, avoid further contrast injections, use IVUS if it is available to guide your management, and rapid stent deployment is the mainstay of management. But if you have lost your wire, ये भी हो गया, dissection भी हो गई है, wire भी निकल गया है. Now, don't lose your nerves. Again, parallel wire technique. You can keep a wire in the dissection flap. If you think that this is not going in, leave the wire there and try another wire. Use IVUS, and don't forget the emergency cabbage is also an option with mechanical circulatory support may be required. So finally, this is for the consultants. This was said by Mark Twain. Good decisions come from experience and experience come from making bad decisions. But for the post fellows, I add this thing. You don't have to do your own bad decisions. मुझे कोई मिला नहीं इसके भी नीचे नाम लिखूं, लिहाजा मैंने कहा अपना ही नाम लिख लूं. ओके, थैंक यू. थैंक यू.